So Mona asked me to give my thoughts about the future of recovery or recovery science after stroke, and what's the path forward. I think there are many paths forward, and I wouldn't get stuck on the ideas that I will put forward in this talk, so much as be encouraged that there's lots more that can be done to help the stroke survivor. And I will give you my personal vision of what a path forward might be. As you can tell from Mona's introduction, I think the punchline of what I have to say is more rehabilitation trials. And it's just my opinion, and my opinion is biased, but I think we learn so many things from trials that allow us to do two things. When a trial is positive, we can reject the null hypothesis and move to the intervention that the trial is testing. But equally, and actually more frequently, trials aren't positive. Some are outright negative and show that an intervention is harmful. And there, the alternate hypothesis is we don't need the intervention. And that's a very good thing. And then lots of trials are neutral and have trends towards being positive or negative, and they're informative as well. They tell us that we're not doing the intervention in the way that we should do it. And maybe they're telling us the intervention doesn't work, or maybe they're telling us we have to do things in a different way. How does trials fit into the academic principles at Johns Hopkins, at the Sheikh Khalifa Stroke Institute, and across the world in terms of all the cooperating institutions that are part of the Sheikh Khalifa Stroke Institute? We think of daily life in our area as research, teaching, and patient care. But I've put on the outside of this Johns Hopkins triad of faculty activities. Research is driven by data from trials and strategies from animal models, and I'll talk a little bit about both. Patient care is driven by two things: data from patient care and strategies from trials. And although evidence basis for care is important, you can't do a trial on every factor of care. And that's where data from care, or one of the two places where data from care is very important, because we can track many of the elements of care and look at their associations with well-being and improvement, more so than we can do in a trial, which is usually limited to major interventions with large effect sizes, which is the difference between the treatment with and without the intervention. And then finally, in teaching, we have evidence-based data which comes from trials. And we have strategies from empiric practice. Again, for the same reason, you can't do a trial on every element of care for every patient. So we have to be open to strategies that come from empiric practice that may be the subject of the next trial that goes on. So I think, as you can see, daily life at Johns Hopkins and other learning institutions is surrounded by data from trials. This is a slide from the pharmaceutical industry on the development of a new treatment, which is the purple column, third from the right, shown here. And you can see that the funnel is a very wide funnel. If it's a drug treatment, starting with 5,000 or more compounds, doing preclinical testing in animals and cell systems in 250 different instances of those 5,000 compounds, as many as 5 phase 1 trials, and leading eventually to one pivotal trial and one FDA-approved drug that meets evidence base. So the funnel is very wide, and not every trial works, not every drug works, not every treatment works. I'll give you another example of this in a minute. But what's important is what you learn in doing those trials. And you learn a lot about the standardization of patient care, and you learn a lot about who and what are the descriptors of the target population. Yes, it's a broad funnel, but it's a funnel in which you can learn a lot about your patients and learn the common language that describes the patients who are eligible and those who are ineligible. This is a figure that I used in the neurointensive care unit symposium a year or two ago. And it's all the trials that have come out of the neurointensive care unit in its 40 years of existence. We started doing trials early in the course of the ICU, and in many different areas, in areas of electrophysiology, brain bleeding for ICH and interventricular hemorrhage, in subarachnoid hemorrhage, and in brain infections. The green circles are the trials over the last 40 years that have been positive and shown either rejected the null hypothesis for the primary endpoint or for a major secondary endpoint, and led to changes in practice. And you can see that there are only, I think, 6 circles there out of many efforts. And this is another way of looking at this growth of information that comes from trials. You'll notice, and it's been my bias that I've focused on intracranial hemorrhage, ICH, and interventricular hemorrhage. And in those areas, there's a positive trial in each showing benefits in mortality. They did not show benefits in functional outcomes, just trends. But what you see is that there's some value in stacking one trial on top of another and learning from each trial how to improve the approach to patient care. So what do we know about human stroke recovery? Here are 6 bullets that come from my trials on brain hemorrhage, which is the less common cause of stroke, but they are have been demonstrated in ischemic stroke as well. Small strokes recover faster than big strokes. Return to baseline function for the patient is not likely after bigger strokes or bigger hemorrhages. Acute post-injury impairment measured by things like the NIH stroke scale or the Scandinavian stroke scale or limb-specific scales predict the extent and the timing of recovery. So the greater the impairment, the longer the recovery, and the less full the recovery. The NIH stroke scale predicts the amount of recovery in a proportional way. So the higher the stroke scale, the lower the amount of recovery. So it's a smaller proportion of normal function. Medical comorbidities limit recovery, and mood plays an important role in determining the extent of recovery. And I'll show you some examples of these last 2. This is a prediction of recovery on the y-axis. It's the proportion of brain hemorrhage patients who reach the modified Rankin score level of somewhere between 0 and 3. 0 being completely normal and 3 being able to live at home and independently care for daily needs. You can see that we can predict about 80%, which is the blue line here, of recovery based on established severity factors. And there are 2 kinds of severity factors in both hemorrhagic stroke and ischemic stroke. There's stroke-specific ones, and for hemorrhagic stroke, it's your presenting Glasgow Coma Scale, the location of the bleed, the size of the bleed, and the size of any interventricular hemorrhage. And then there are patient-specific factors as opposed to disease-specific factors. The age of the patient, whether or not they have diabetes, and the Physicus score in ICH. Physicus score is one method of measuring the amount of white matter disease that exists, presumably from sustained hypertension and other vascular disease factors. And you can see that we're predicting how well the patient is going to do and whether or not they're going to become independent about 4 out of 5 times. But there are multiple other unknown factors that govern the outcome of the patient as well. I'm certain that one of them is rehabilitation, but we've yet to fully define who we can rehabilitate and how how much each individual patient will be rehabilitated. I'm sorry. There we go. In brain hemorrhage, there's been a tendency to be overly nihilistic because the recovery period is very long. We took the modified Rankin 4 patients who are on the left side of the screen and the modified Rankin 5 patients as assessed on day 30 after their stroke, their hemorrhagic stroke, and then followed them for a year afterwards. And you see that the 4s who have a higher degree of function than the 5s who are totally dependent for their care on others. The 4s improve substantially over the year following the stroke, with about half the patients improving by 1 Rankin score to 3, and about 30% of the patients, 30 to 40%, improving by 2 Rankin points to 2. So recovery occurs, but it's doesn't occur rapidly, doesn't occur in the same time frame as we have expectations for ischemic stroke. If we move to the right-hand panel, even for the 5s, half of the patients who are at 5 at 30 days, and this is a substantial number, 500, half of them, somewhere around 250, have improved at 365 days. So higher impairment, a lower proportion of improvement, but improvement nonetheless. If we look at a different data set, so the data set I just showed you is from the MISTY trial and the CLEAR trial, which was a set of 1,000 patients. If we look for the ERIC cohort, which is a 3,000 patient cohort of hemorrhagic stroke, and we look at the occurrence of either depression post-stroke, PSAD is post-stroke anxiety or depression, as measured by a quality of life scale called the EuroQoL. If we look at the presence or absence of anxiety or depression in the recovery period, and the first panel is 3 months, the next is 6, and the final panel is again 12 months, where there is no, where there is no depression or anxiety, we see almost 65% good functional outcomes. I'm sorry, closer to 80% if we do the 3 cut point, which is the contrast between orange and red here. But a substantially smaller proportion where anxiety and depression are a part of the patient's profile at 3 months. And this same trend occurs over the full 12-month period, suggesting that depression may have a major role in determining what the 12-month outcome is. And I think this is an important and not well recognized comorbidity that probably does need to be addressed in clinical trials eventually. Now, this is that same ERIC data organized, if you look in the left column, by the MRS status, so the functional status or the degree of impairment at 3 months, looking at who has anxiety and depression at 12 months over here on the right. And this is a so-called Stanky plot. And we'll start with 0, no impairment, and the dark blue on the right-hand side. The biggest component of that dark blue comes down to the lower group of no anxiety and depression at a year. But there's a small group that still has anxiety and depression at a year. If we look at the Rankin 1, again, the majority have no anxiety or depression at 1 year. Rankin 2, the same, although a bigger component has some. And Rankin 3, it's about 50-50. Rankin 4, so as you move to higher degrees of impairment, physical impairment does relate to mood as measured by either anxiety or depression or both. So impairment contributes to one's mood. And the question for clinicians that currently is unanswered is, if we're able to engage the patient and alter their mood, are we also better able to engage them in the tasks of rehabilitation? And will the outcome over the rehabilitation period change? So I think this is a nice subject for clinical trial. Here's a deeper look into what are the factors that are associated with good functional recovery at 12 months. And if you look on the left-hand column, what you see is that undergoing rehab by 3 months was a positive factor with an odds ratio of almost 5, which is a significant possible treatment effect. And the second biggest factor is the absence of anxiety or depression, post-stroke anxiety or depression at 3 months, which I just showed you in the previous 2 slides, with an odds ratio of 3. And both of these factors, as suggested by the Corcoran review that Victor showed us, both of these factors have odds ratios that are higher than age, the GCS at presentation, or clot volume. And there are other factors. Did you exercise prior to stroke? Were you employed? That are social factors, as well as the one that we showed originally from our predictive model, the presence or absence of interventricular hemorrhage. So the suggestion from the ERIC data is the same as the Corcoran, that rehab is likely to be helpful in overall recovery, and that a major personal factor that is potentially modifiable, the anxiety or depression state, is another major factor. Switching back to MISTI and CLEAR data, we've looked at what happens between the presentation day, day 1, and day 30 of recovery. And these are the same receiver operator curves that show the likelihood of reaching modified Rankin score of 0 to 3 on the y-axis, and the percentage of patients that are described in the model on the x-axis. If we take data that is part of the patient experience between day 0, which is the red line, and day 30, the blue line, we come up with several factors that allow us to better predict outcome. So we move, whether it's in CLEAR, which is the left panel, MISTI, the middle panel, or all the data together, we move from predicting 4 out of 5 patients' outcome to essentially 9 out of 10, if you look in the far right-hand receiver operator curve. If we take into account the care that has occurred over the first 30 days. This includes multiple factors that represent complications that the patient experiences, many of which are predicated on comorbidities, but some of them are predicated on treatments that have side effects or unpredictable events like the occurrence of a major infection. So what this is telling us is that by the time that a patient becomes a candidate for rehabilitation, much of the current outcome can be predicted on the basis of the initial severity of injury, the red line, and then subsequent effects that occur in hospital and that are part of stroke care. So here's a summary of human recovery data. Stroke severity drives recovery. Depression and anxiety are important, unrecognized factors that frequently influence recovery in a significant proportion of patients. And you saw that proportion both in the ERIC cohort, and the same proportion exists in the MISTI cohort. Personal and social factors are associated with depression and anxiety. I haven't shown you that data, but in the ERIC data, lack of a support system, female gender, and Hispanic ethnicity were important factors leading to a higher percentage of patients suggesting they had depression or anxiety. Trials of antidepressants utilized during early recovery are probably needed. So again, the idea that if we gather data, organize it, we can then go out and test hypotheses. What do we know about stroke survivor rehabilitation? Rehabilitation is offered early to survivors of mild stroke, and perhaps a bit later or never to survivors of severe stroke. Successful rehabilitation occurs with guidance from, I think, 4 major groups. physicians. The primary guidance is coming from physiatrists or physical and rehabilitation medicine specialists, but also in coordination with primary care physicians like internists or neurologists who are stroke neurologists, and offering specialized management of secondary problems, such as stroke prevention after stroke. But also therapists, and therapists do the majority of the work, whether they're physical therapy, occupational therapy, or speech therapy. I think there's a role for exercise physiologists as well, and I'll show you some information about that in a minute, and caregivers. And the ERIC data suggests that support systems are important, and I think they're another very underrated component of recovery. Currently, rehabilitation is undertaken by stroke survivors with a range of expectations and a range of personal support. And not understanding the differences in expectations and personal support is probably a part of why some rehabilitation efforts aren't as successful as others. It's my experience that survivor goals and their perceptions of those goals drive any individual rehabilitation effort. Here's some data from MISTY, so again, hemorrhagic stroke, showing the stroke impact scale, which is a patient-reported scale, a PRO, patient-reported outcome, and how the scores change over the initial year after stroke. And you can see the blue line is strength, the red or magenta is mobility, the green is activities of daily living, and the orange is hand function. And the left-hand panel are the Rankin 4 patients, and the right-hand panel are the Rankin 5. And we again see that less impairment leads to a greater proportional recovery, with the majority of the recovery occurring over the first 6 months, but significant changes occurring over the next 6 months. That curve is less steep for the higher impairment, the Rankin 5 in the right panel. But ongoing improvement, perhaps even a greater degree of ongoing improvement, goes on between 6 months and a year in the Rankin 5 patients. And some of this may relate to medical comorbidities that dominate the first months after a stroke in a severe patient. And some of it may relate to active disuse when you are severely impaired, and that it takes a much longer period of time to recover full body functions. And we'll look at that idea in a little later point in this talk with some different slides. I think this is these are the cognitive non-physical domain recovery scores from the hemorrhagic stroke patients in MISTY and CLEAR. So memory, communication, green is emotion, and orange is is participation. And you definitely see that the non-physical scores are not as limited as the physical scores are in terms of the difference between the rank and 4 on the left and the rank and 5 on the right. But you also see the same trend that greater impairment decreases the total amount of recovery, so the recovery is proportionately less. Another patient-reported outcome is the Euroqual. This is the simplest of the Euroquals, the visual analog scale, which just says, how good is your health today, with 0 being the worst down at the bottom and 100 being the best. And this scoring system has been used widely across multiple diseases and is quite reproducible, and there are lots of normative population data for it. Most of us don't answer this question as 100, and unfortunately for people like me, the older you get, the lower the score, such that somewhere around 75 is the norm for people between 65 and 80, for example. And there it is, 74.9 for, I'm sorry, 45 to 75 plus. So this is the Euroqual on the y-axis, separated out by different Rankin scores. For misty and clear patients who survived to a year. So of the 500 misty and 500 clear, 300 plus survived a year. The dashed line is the age-related norm for the 45 to 75 plus age groups. And you can see as your Rankin score or functional ability is less, the Euroqual decreases as well, which is appropriate. But what you see also is that there's not much scatter for the Rankin 0, whether it's in misty on the left or clear on the right. But as you go down in Rankin score, the whiskers, the straight lines, the straight vertical lines, begin to cover the full range of the Euroqual, such that the average Euroqual for the Rankin 4s is down around 60, and for the Rankin 5s is down around 40 in misty, and lower 25 in clear. But there's a big scatter. So some people in their recovery at a year appreciate a high degree of well-being, even above this average, while others don't appreciate well-being at all. Whether there's a component of behavioral perception, whether there's a component of accommodating to disability, all of these issues need to be better studied if we are to more fully engage our patients in rehabilitation activities. This is the same data, but just for the misty patients. And these are some age-matched patients, age and disease-matched patients at 30 days, 180 days, and 365 days. And you can see that patients in rehab and patients at home, as opposed to those in a long-term care facility or acute care, tend to have a higher sense of personal well-being. And by 365 days, this match group approaches that are at home approach the U.S. population norm. So recovery can be robust, and a person's feeling about their recovery can be very positive. So here's a summary of stroke survivor data taken from our ICH experience. Stroke recovery takes a year or more after ICH. Low day 30 Rankin does not always predict poor recovery. Recovery is proportional to the 30-day Rankin status. Patient-reported outcomes are better than expected, certainly better than we've been telling our patients what to expect in the neuro intensive care unit. And perhaps we should be utilizing some of these now established quality of life measures, like the Euroqual, more often when talking to stroke survivors and their families, to give them a more realistic expectation of what the path of recovery is, the time of recovery, and why multiple personal factors, such as family support and mood, are important to recovery. I'm not going to spend time reviewing animal models, but I want to give a list of things that I've taken away from animal models and rehabilitation. Enriched environments promote recovery, and certainly the rehabilitation program and the rehabilitation hospital environment attempt to provide enrichment. Repetition of movement improves performance, whether it's reach and grasp or treadmill for walking and balance. And plasticity tends to occur, cell-based evidence of plasticity tends to occur in the presence of neural growth factors and with the release of axonal outgrowth inhibition. So there are biochemical factors that appear to be part of why we see some signs of neuronal plasticity. And this occurs also with electrical brain stimulation. So the promotion of plasticity is associated with improved motor performance. And the functional improvement post-stroke requires both repetitive motor activity or training or rehabilitation and brain exposure to plasticity factors in animals. Presumably the same program is occurring in humans. We saw this in a trial of progressive treadmill training in humans, a sample size of 71 patients from the University of Maryland who were exposed to 6 months of treadmill exercise, which improved walking velocity by 51% and measures of cardiovascular fitness by 18%. And these are those improvements in peak effort and treadmill training, 6-minute walk time, uh, peak oxygen uptake, VO2, and the 10-meter walk times, with the red being the cohort who were exposed to treadmill training, and the blue being the cohort who got attention but not the metabolic training. These same patients, and this is a subset of 32 of those patients, and their merged functional MRIs showed activation in the cerebellum, in the left-hand panel, the red nucleus of the midbrain, and in the hemispheres, when comparing their before fMRI to their after training fMRI. So it looks like plasticity can occur in humans. Similarly, in an arm training program, 6 weeks of bilateral rhythmically cued training on an arm rowing machine induced bilateral cortical activation, the red areas, in 6 of 9 exposed patients, with the cohort showing a 5-point Fugel-Meyer improvement in arm performance. So it looks like the animal models of recovery can be recapitulated in man. And more trials are needed in this area for neurorehabilitation. The last point I want to make is we're currently working with a group of investigators from New York to attempt to develop a trial called CROSS, which is for people who have either ischemic or hemorrhagic stroke, are medically cleared by a cardiologist, and will undergo an approved cardiac rehabilitation program that's standardized by the American Association of Cardiovascular and Pulmonary Rehab program. They only have to be able to stand and walk without assistance for 10 feet, and have the ability to transfer on and off a recumbent bike, so that balance is not an issue. And the trial is going to, we hope, if it is funded, is going to compare standard stroke rehab versus standard stroke rehab plus cardiac rehab, which gives you that metabolic boost. Here's some preliminary data. The stars are the group that got cardiac rehab, and the triangles are matched patients who didn't. And you can see that mobility, daily activity, and cognitive domain all improved over a 3-month period of time. Metabolic activity improved over the same 36 sessions, 3-month period of time, with 100% improvement in METs, one measure of exercise. And survival after rehab in matched controls was better in those who had the cardiac rehab than those who did not. We have to be careful because these are not randomized patients. So these are my non-evidence-based shortest path to better recoveries. Reject nihilism, optimize stroke survivor goals, diagnose and treat clinical depression, develop a progressive training program based on practice and repetition. I would disbelieve in the notion of a patient having a plateau. I'd find training tasks that engage the survivor, calibrate tasks so that learning is a challenge, but not impossible, and where needed, switch therapists. Utilize activity data and take rehab holidays. So I'd like to end with the idea that stroke recovery is a cooperative effort. Thank you very much.